Hello everyone, and welcome to the next segment of the Rehabilitation Techniques module, Joint Mobilization. In this segment, we will discuss the key concepts that are associated with performing joint mobilizations, and you will be provided a number of example maneuvers for the shoulder and ankle. Although joint mobilizations can be performed at many different joints throughout the body, we will focus on the shoulder and ankle because 1, they tend to be the mobilizations you will utilize most in clinical practice. 2, they have the most information about them in the literature. And 3, you will be asked to demonstrate joint mobilizations for the other anatomical joints during our face-to-face lab time. The goal for this segment is to help you understand the key concepts that apply to all joint mobilizations so that you will be able to effectively employ maneuvers to overcome pain, limited motion, or both. So let's jump right in and briefly review the information from your readings. The systematic reviews you were asked to read highlighted 3 overarching points regarding joint mobilizations. 1, joint mobilizations are primarily employed to decrease pain. 2, high-grade mobilizations are more effective than low-grade mobilizations for improving motion. And 3, joint mobilizations, while effective, should not serve as standalone treatments. In other words, they should be employed with other interventions to help achieve the desired effect. Before we can begin applying joint mobilizations, however, we need to understand the concepts. The first key concept is understanding joint play. Simply stated, joint play is motion that occurs at a joint based on its architecture. There are 2 types of motion that need to be explained. The first type is known as physiologic motion. Physiologic motion, or osteokinematics, is simply the motion that occurs from muscle activity or gravity. Physiologic motion is voluntary, such as the gross actions of flexion, extension, or abduction. Conversely, accessory motion, or arthrokinematics, is the motion that occurs between 2 articulating surfaces and is considered involuntary motion. For example, when you elevate or flex your arm in front of your body, you do not consciously control the motion that occurs between the glenoid fossa and humeral head by saying, I must make my humeral head spin posteriorly in order to elevate my arm. So let's look at the 5 joint play motions that exist. First, a roll. A roll is defined as multiple points of one joint surface contacting multiple points on another joint surface. This is best illustrated with the humeral head contacting the glenoid fossa during abduction and adduction. Second, a slide or a glide is defined as a single point on one joint surface contacting multiple points on another joint surface. This is best illustrated with anterior or posterior translation of the talus within the mortise when you move into plantar and dorsiflexion. Third, a spin is simply the rotation of one joint surface on another joint surface. The spin essentially occurs around the joint axis. This is best illustrated with shoulder or hip flexion and extension. And then finally, we have compression, which occurs when 2 joint surfaces are pressed together, and we have distraction, which occurs when 2 joint surfaces are pulled apart. Now, while you do not consciously control these 5 actions, the arthrokinematic or joint play motions are necessary for ranges of motion to occur. Our next concept, joint position, is broken into 2 pieces: closed-packed and loose-packed joint positions. The closed-packed position is where the joint surfaces have the greatest amount of contact and where the least amount of joint play occurs. This position is considered to be the most stable, but it is not ideal for performing joint mobilizations. Instead, we perform the maneuvers in the loose-packed position, or the position where the most amount of joint play occurs. The loose-packed position is characterized by the least amount of contact between joint surfaces and is preferred for joint mobilizations because the clinician has the freedom to stress the joint and the surrounding tissue without causing compressive damage to the joint surfaces. Essentially, the clinician attempts to create as much space between the joint surfaces as possible in order to have space to replicate the joint play motions. Our third concept is understanding convex-concave patterns. The easiest description I can provide is that the direction you push or pull is based on the architecture of the bone you are pushing or pulling. In other words, the joint surface of one bone is convex and the other bone's joint surface is concave. If the surface you want to move is convex, then you push or pull in the opposite direction as the osteokinematic motion. If the surface you want to move is concave, then you push or pull in the same direction as the osteokinematic motion. This brings us to our final concept, which is understanding the different joint mobilization techniques you can utilize. There are two traditional techniques, Maitland oscillations and Kaltenborn tractions. First, let's talk about the Maitland oscillations. There are 5 grades of oscillations you can perform, each described by 1, the intensity of the mobilization, and 2, a point in the range of motion where the mobilization or mobilizations will occur. Because the Maitland technique is describing oscillations, you will bring the patient's limb to the desired position in the range of motion, and then repetitively push or pull in a single direction. These mobilizations are considered serial mobilizations because of their dynamic nature. Maitland grades 1 and 2 are considered to be the best for pain reduction, while grades 3, 4, and 5 are considered ideal for increasing limited ranges of motion. It is important to note that we tend to avoid grade 5 mobilizations because these are considered dangerous. They are characterized by a quote-unquote thrust, which is a high-intensity movement designed to loosen or break scar tissue. And that can unfortunately damage the surrounding tissue to a point that it will cause further injury. Next, we will talk about the Kaltenborn tractions. There are 3 grades of traction you can perform. However, unlike the Maitland grades, the traction descriptions are more general and are more subjective. Because the Kaltenborn technique is describing traction, which is simply static distraction, you will bring the patient's limb to the desired position in the range of motion and then pull the joint in a single direction. The static nature of these mobilizations are considered safer. However, the clinician must learn to apply the 3 different grades of distraction force through practice and in a manner that does not exhaust him or herself. Now it is time to demonstrate the application of joint mobilizations. You will be provided 2 examples for the shoulder and 2 examples for the ankle. However, there are a few practical tips to provide to you prior to performing the mobilization maneuvers. Your evaluation is key, so your exam should guide your treatment. First, begin by assessing the patient for the presence of what is known as generalized laxity. General joint laxity is common and non-pathologic. However, there are cases where general laxity can create a challenge for clinicians because the expectation on exam is normal tissue integrity. If your patient is deviating from normal tissue integrity, well, what does that mean? To determine if the tissue is non-pathologically lax, there are 5 tests you must perform. So first, you will passively move the thumb to see if it goes parallel to the ventral aspect of the forearm. The second test will be to determine if the fingers can be pulled parallel to the dorsal aspect of the forearm. Third, you will ask the person to extend their elbow to determine if they have 10 degrees or more of elbow hyperextension. You will also see if they have 10 degrees or more of knee hyperextension. Finally, you will determine if they have 40 degrees or more of dorsiflexion. So if any 3 of the 5 maneuvers are present, then you can say the person has generalized joint laxity. However, if the patient has a history of joint luxation, whether dislocation or subluxation, they are generally lax, and they have persistent dysfunction and pain, then pathologic tissue laxity or a genetic condition such as Ehlers-Danlos syndrome may be present, which suggests that a referral to an orthopedic surgeon would be warranted. Next, the clinician must perform a complete motion assessment with a goniometer or other measurement device. This segment will not review these techniques. However, the point must be understood that objective measurements of motion must serve as the justification for applying joint mobilization. Visual observation is not an acceptable method of motion assessment. There are also 6 contraindications for the performance of joint mobilizations: bacterial infection, recent fracture, joint hypermobility, as I just described with laxity, neurological involvement, bone disease, or inflammatory arthritis are conditions that if they are present, then joint mobilization may not be performed. Now, as we get into performing the joint mobilizations, there are 4 considerations for all patients that must be accounted for. First is patient position, such as being in the supine position, prone, side lying, sitting, standing. You must make that determination. Limb position will depend on the direction and location of the restriction. And then finally, the placement of your stabilizing hand and your mobilizing hand. We will account for these items for each specific maneuver performed. So we will begin with shoulder abduction. So to begin with shoulder abduction, the patient is in a supine position. you are going to move the arm to the position of treatment. Your stabilizing hand will be at the elbow. Your mobilizing hand will be over the humeral head next to the acromion. You will apply distraction, and then a downward force will be applied to the humeral head, and you will pivot with your body to perform the mobilizations. Now, based on the Maitland grade of oscillation you are choosing to perform, depress the humeral head inferiorly to the certain depth that is needed for that grade, and make sure that you pivot with your body in order that you do not tire yourself out. This is important also so you do not perform additional stress to the joint, increasing the chance of injury. To gain external rotation, again, the patient will be in a supine position. You will bring the arm to about 90 degrees of abduction, and you will ask the person to rest their hand against the side of your body. Your stabilizing hand will be at the elbow, and your mobilizing hand will be over the humeral head next to the acromion. You will use your thigh to support the limb, and you will inferiorly depress the humeral head towards the floor in order to help gain external rotation. So to gain dorsiflexion of the ankle, you will stabilize the tibia and fibula. You will place your hand over the talus, making sure your thumb and index finger are below the malleoli, and you will posteriorly glide or slide the talus in order to gain dorsiflexion. Now, in order to gain plantar flexion of the ankle, you will have the person in a prone position. You will place your stabilizing hand over the tibia and fibula. You will have the foot in a slightly neutral position. You will place your mobilizing hand over the Achilles, making sure your fingers are below the malleoli, and then you will inferiorly depress the talus towards the floor. The final concept, or the final tip I should give you, we did not discuss dosage. Dosage is not standardized, and so the recommendation from clinical experience to provide to you is to apply one set of 5 to 10 repetitions of the mobilization you're choosing to utilize at the grade you feel is appropriate to begin with. If the patient tolerates it well, it is permissible to do another set of the same number of repetitions. However, if the patient does not tolerate that well, if it causes increased pain or makes them more uncomfortable, then the suggestion is that you should stop there and try on a different day. You may need to use other modalities, you may need to use other resources or interventions to help control pain and increase motion, but that is your choice, and that is the art of being a clinician.